Hi, I'm Peter Llewellyn of NetworkPharma TV. This is one of my unscripted conversations, as I like to call them, when I invite people that I think have got something interesting to share with us. So let's see what we learned today. Eugene, you're joining us, Eugene Pozniak, in your role as founder and program director of the European CME Forum. For full transparency, let's tell everybody I was the co-founder many years ago, and for a few years worked with you on those meetings and activities, and then I sort of concentrated on the medcoms work. So we're going to use the fact that the 18th meeting is coming up in November. So I think it's the 5th of November, 2025, as we're speaking at the moment. So that's a big milestone. So I'm using that as a bit of an excuse to get you on and to talk to you about the current state of CME, or continuing medical education in Europe, but also more broadly across the world. But can we start, Eugene, with you telling us in your own words who you are, what you do, and how you got there?
Brilliant. Hi, Peter. And thanks a lot for inviting me to one of your informal chats. And you're right, yeah, sort of with the 18th annual European CME Forum coming up, it feels like it is a bit of a coming of age. So, no, I've been around the block quite a few times in various guises over the years. You know, in the 1990s, like my last kind of job working for pharma was in medcoms. I had a few years in medcoms. And around the turn of the millennium, I started working in CME. I was changing jobs going between agencies, and someone said, "Hey, why don't you employ your digital skills in developing what became the first pan-European accredited e-learning system, which we did for the European Society of Cardiology." And I just stayed in CME ever since. So it's now 25 years of working in continuing medical education. We got together when I set up my own education company, which was called CME Learning. That was like 19 years ago. And you were publishing these reports,
That's right, yeah.
you know, the white papers and things. It's still available, the one we did together. And we, of course, we did a few meetings around London, Oxford, and Manchester, wasn't it? And there was quite a bit of interest. And we said, well, what's the next step? And you suggested, why don't we actually create a meeting? So
Exactly, yeah. That was over a pint, wasn't it? That was the danger of going to the pub and having a bit of a chat, is you come up with ideas like that.
yeah, so he said we'll do this one-off meeting, and we had a whole load of the accreditation bodies turned up, drug companies as funders of CME turned up, and in those days it was all medcoms agencies really as the education companies creating the CME programs, and yeah, we put together that first meeting. And during the meeting, people say, "Hey, this is great. Where are we going to have the second meeting?" And so it carried on. And so I carried on with the European CME Forum things. Meanwhile, in parallel, I ran the education company. And actually, I sold that earlier this year. So I'm no longer involved in the accreditation side of things. You know, got accredited by the ACCME, and it did a load of, basically I was walking the walk of being an education provider, you know, of accredited CME. But you know, European CME Forum has just carried on over those 18 years that it's been running. We've got our own peer review open access journal, the Journal of CME. So that's just jcme.org. And we pulled together as like a special interest group of education providers across Europe. We've got like 15, 17 members year on year, called the Good CME Practice Group. So so that carries on. So it's like an association for people working in and interested in presenting CME in Europe.
Excellent, excellent. And let's go a bit broader, okay? And let's set the scene a little bit, because I'm always slightly surprised when I'm talking to people and people don't know what CME is, or so okay, we say continuing medical education, but what does that mean? And when we started it 18, 19 years ago, there was quite a big difference between the state of play in Europe and the state of play in the States and the rest of the world, which is part of the reason we did what we did. But just briefly, let's not get bogged down in this, but give us a sense of some of the terminology and some of the differences on how things have evolved over the last 18 years or so.
So CME itself, yeah, continuing medical education, is that sort of third phase of education of the specialists, of doctors. You've got undergraduate education, the stuff that the students learn at medical school. Then you've got the specialist, then you've got the graduate education, the Americans call it, but the actual education on the journey to becoming a specialist, so specialist training, F1, all the way up to sort of the fellowships or members of the Royal Colleges and becoming a consultant. But once a doctor becomes a consultant, then formal education is finished. And what do they do for the next 30 years of their career, 35 years of their career?
Right.
And it's a matter of keeping up to date. That's a continuing bit, continuing medical education. In the UK, it's called continuing professional development. So CPD, a few countries call it CPD and variations of, because of course not every country in the world speaks English. So you're going to have a whole host of acronyms, but we've called it CME over the years. And also, let's say in the websites and stuff, we're now calling it CME/CPD, because CPD is a term that's being used more often. And some people do distinguish between the different things,
Right.
Especially if you're an educationalist or an accreditor. You'll say CPD is looking at your own professional practice, the 360-degree reviews, blah, blah, blah. And the CME, there's medical education, that's going to conferences and doing e-learning and things. But once you're sort of looking at it as an overview, as an industry, an environment or whatever, CME, CPD is interchangeable. And especially the stuff that we're talking about a lot of the time in Europe, especially, is a lot of it's funded by pharma.
Yeah.
So, pharma's not going to look at the professional practice of individual doctors, so pull back again. So we're talking CME.
Okay. And just sorry, I did ask. So let's not lose that. The difference between the States, Europe, the rest of the world, because that's changed a lot over the last few years, hasn't it?
Yeah, it has. So CME has been going since like the 1970s, 90s, 1980s in the US. The Canadians have been really good at the academic pursuit, the actual getting educational theory involved. North America, the US and Canada have been doing CME in some way for much longer. No, they started off in the US. There's the Accreditation Council for CME, the ACCME, which has been going since I don't know, a very, very long time. It's like mid 80s, 1980s or something. And they are the standard accreditor. Yeah, most education in the US is done through ACCME accreditation process, and they've sort of set the tone for the requirements. So it's there's got to be educational value in the CME, and it's got to be independent of industry control. So whoever's funding it. So that's been going forward, and of course, as we know, it's like half of all pharmaceutical sales in the world go through the US. So the US drive a lot of policy. They've got a lot of clout. Meanwhile, in Europe, CME only got going in Europe. I mean, my first experience was in 1996. I remember this. I was thinking about it not so long ago. In the UK, there was a thing called the PGEA, the Postgraduate Education Allowance. If you remember, the government cut £2,000 from the GP salary each year, and they said you can get that £2,000 back if you do your PGEA. I think it was like 30 hours of education at that stage. So that's an early example. Different countries had different things, but it seems like 1999, 2000, most countries adopted some kind of CME system, and they've sort of glanced at the US system, but looked at things internally. And generally, CME means doing about or exactly 50 hours of education per year in order to get some kind of benefit. And you're going to ask about the difference, pull me back on the difference. So the US it's just much more strict. In Europe, different countries have different requirements. And the accreditation isn't as strong in Europe, nowhere near. Like in the UK, doctors can actually self-certify. So you go to see your own GP or hospital doctor or whatever, and they'll say, "Oh yeah, I went to a conference and I just signed it off." There is a formal process they go through where they through a self-reflection process where they actually say, "I turned up to this conference for 6 hours. It met my own learning objectives that I've agreed with my appraiser." And it's an appraisal system that's checked through each year. So that's our system sort of in the UK, and there's just variations of this across Europe. The big difference between US and Europe, and over this sort of 18 years, there was It started off, let's say, when we started off European CME Forum, that was like in the real early days. Medcoms agencies were involved. You were involved, because it was okay for the promotional side to be involved in CME. So even when I was doing it in the early days, I was working for a Medcoms agency,
Right.
and we just said, yeah, this is an accredited program, and we would go to the accreditor and say, yeah, the drug company hasn't developed any part of the education. I mean, they directed what it was. They were involved to a degree. They helped with recruiting delegates and things, and they were sort of semi hands-on, but we as the agency presented it. And as the standards evolved, if we call it that, and then CME got entrenched, in Europe, people were saying, well, hang on, it shouldn't have that much control by the pharmaceutical industry or the funder. So the rules got strengthened year after year. And that's when, eventually the Medcoms community started pulling away from CME, saying, actually, we're not compliant to do this. And then we had the rise of the actual dedicated CME, the education providers in Europe, like the members of the Good CME Practice Group and the kind of company that I just that I was running. And this is more sort of a US expectation. And then to raise money for a CME activity, an organization that doesn't do work for pharma companies, that the Americans would say that doesn't advocate for pharma. So all variations of being connected to a pharma company. So you're not allowed to have any connection there. And that organization can apply to the pharma company for funding. And it's that way. It's got to be the education provider requests from the drug company the funding to run an educational activity. So then you've got that sort of visibility. The drug company is not driving the agenda of the activity itself. So that got stricter and stricter in the US, and it's very well established. And in Europe, as it got stricter, yeah, the Medcoms agencies pulled back, and the FPIA started getting involved in this as well, because there was no regulation around this in Europe.
Right, exactly, yeah.
Yeah. So, yeah, and then that takes us to the sort of the next stage. But should we have a little breather there? I don't know if that sparks anything.
No, this is all great stuff, right? So let's keep pursuing it. Let's keep going. So, I mean, it obviously I've stepped back from it for a number of years, but the point of the ECF, the European CME Forum, when we started it, and as I see it, is still there, is that sort of, I was going to say neutral. Is that fair to say neutral forum where you can bring those different regulators and so on together? It wasn't. I mean, the US. Let's be simplistic about it. The US has one overarching sort of body, as it were, and then in Europe, it wasn't even just by country. Different specialities have different accreditors and so on. I mean, there's all sorts of people playing around that, and European CME Forum was able to bring that group together, wasn't it, from the different sides? And out of that, I mean, I feel quite proud of what we did, because I think what you're doing is you're sort of helping them sort of, I suspect it's like herding cats. I think that's probably a reasonable expression in some ways, but to some extent, you're giving them an opportunity to talk to each other and to go in a direction, which is complicated and political and can be a bit chaotic, can't it?
Yeah. No, and especially in the early years, I mean, we described it as a boxing ring kind of thing.
Yeah.
2 or 3 days, and it was just a safe space for heated debate. They really were quite quite lively, and but once people realized actually we're pursuing the same aim, there was a lot of suspicion between the accreditors, the House of Medicine, the doctors, the Royal Colleges, the accreditation bodies, saying, oh, all drug companies want to do is promote their product. And it's like, especially the bigger companies just going, no, it's all right. We've got our sales force, we've got our advertisers, we've got our Medcoms. We're doing all of that. This is something else that we're giving back. And it's sort of, in those days, we'd say it's like giving back to the community. And it's like you drive through towns, mostly in the south of England. I don't see them up here in Manchester, but you might have a roundabout that's sponsored by McDonald's or something, or by the local building company. Well, what's McDonald's doing building roundabouts? No, they're not. They're just giving back to the community, and they're paying a few quid so a gardener goes around and keeps it tidy. So that's what CME is about. And actually, what's quite depressing is even today, people still think, oh, all drug companies want to do is push their drug. And it's not that. And you come to the European CME Forum meeting, we'll have drug company people there who are actually saying absolutely explicitly, as soon as they sniff that you're trying to somehow promote their product, or you'll do your needs assessment. There's a process to doing it, but I think everyone listening to this podcast understands how to put together medical education. But if you sort of describe the medical education you're proposing with the objective of pushing the drug of the drug company, that's like an automatic rejection. They're saying, because they are going to be the ones in trouble, especially the US headquartered drug companies. If they are seen to be supporting education that promotes their drug, they're in trouble. Yeah, it won't necessarily be the education provider. And over the years, the American companies especially have got stricter and stricter. And then you'll have these applications, and you'll say, oh, why is it that drug company X is wanting to support education in sub-Saharan Africa in an area that's a fringe interest for their drug? They say, well, because that's exactly what they're doing, is they're trying to promote good education, not their products. They are actually trying to do something good there. I mean, of course, not everyone is that. What's the word? I always forget it.
Charitable or purist, or what do you want to call it? But one of the things you touched on then is maybe worth highlighting, and it's certainly something that I've always seen from where I've sat with CME, is there is that process, needs analysis. There's quite a rigorous process of defining why you're doing something, and then measuring outcomes. And certainly from a medcoms point of view, I've always been quite public about the fact that we need to do more of that sort of thing in medcoms, and I think it applies to a lot of other areas as well. CME was always, from my point of view, well ahead of the curve in terms of saying we need to know why we're doing something, and then we need to work out whether we've achieved something at the other end. Yeah, and I think I've led the way there. And there's the whole sort of thing about the Moore's pyramid and all the rest of it, which people can go off and Google it a bit more. But the idea that you can, are you measuring just bums on seats as a satellite meeting, or are you measuring some sort of actual effect? Yeah, that's taken very seriously by that community, isn't it?
Oh, absolutely. And that was a big eye opener for me. And that's what excited me about CME in the first place. Right. So this was, 25 years ago, or whatever, even then. But that Moore's outcomes framework, Don Moore, who's actually coming to the meeting this year as well. He's a lovely guy, past retirement kind of thing. But he wrote this paper in the late 90s, I think it was. And he's updated it, and he's published in the Journal of CME as well. And the presentations on the website and things. And he came up with this outcomes framework. And he says all he's doing is standing on the shoulders of giants by just getting a lot of the educational theory that was done in the 70s and 80s and just put it into context in medical education. And it was that, this outcomes framework's got 7 steps. And as you're saying, the first one is participation. So, and it can help guide. And the medcoms community would absolutely learn from this. And I do hear some companies coming out with like snippets of this theory, and people say, oh, this is really interesting, this is cutting edge. You go, no, it's not. No, in CME, we've been doing this for a long time and to a much higher level. And it's an academic pursuit. So also to people, don't make up words for clever things you invent in the office. People have worked this out in the 1980s, and there are standard wordings that the drug companies know about, because of course the CME departments and whatever, they know these. But the basic level, you've got participation, bums on seat, as you say. So in the 90s especially, I did a satellite symposium. You have a satellite symposium room for 400 people. Standing room only. You had more than 400 people there, and everyone applauds, going, "Wow, that was amazing! You did such a great job. Have a bonus." And it's got no. It was raining that day, and you had 200 people waiting for coaches. That's why they were in the room. Yeah. And then the next one is, well, how happy were they? So level 2 is your satisfaction. How happy were they? How did you know? Oh, wow, we did the survey, and they're all really happy. Well, of course they were happy, because you gave them lunch, or dinner or something. Yeah. And then the third level is knowledge. That gets tough. How do you work out if someone's learned anything from your education? And so there was a big time about big effort, especially with e-learning. You have to test people, 10 questions, multiple choice quizzes, blah, blah, blah. But everyone's got fed up with doing multiple choice quizzes anyway. But someone might learn something in that conference, or the e-learning or the symposium, whatever it is. That's a level 3 outcome. But now in the CME world, those three levels are just completely ignored. There's some drug companies, we're not interested in that. We're interested in level 4. And it's how will you change someone's competence? As a result of taking part in this education, what will you do differently? I'm going to say that's the first question we need to, we need to know how many people are in the room or took part, but we really want to know what's the actual impact of your education. And then the levels carry on up to, no, I don't need to go through the levels, but
no, we probably shouldn't. And it's worth, I was just thinking as you're talking, I mean, there's a lot of information now. I mean, frankly, I'll put in a plug for NetworkPharma TV because people can find a lot of videos with you and with the GCMEP group and so on and so forth. There's quite a lot to learn there. Your website at cmeforum.org is actually a very, established and large repository of information about CME and so on. So perhaps we should allow people to do a bit of research there. But I think it's interesting to give people some of the ideas as to the principles that are applied within something like CME. And all I was going to do was, without wanting to get bogged down in it, was go, and really what ultimately matters is what happens to patient outcomes.
Yeah.
And can you, and actually it's very easy to say that's what matters, let's measure it. It's quite difficult to measure it and so on. So there's a real world and there's a sort of an academic sort of, this is what we're aiming at and aspirations and so on. So there's a lot of ground you covered there, which we could go into more detail about, but let's not. And as I say, people can go and do a bit of research. I'd quite like to spend just a little bit of time specifically about 18 ECF, if that's the right nomenclature still. The 18th meeting of European CME Forum coming up in November, as I say, as we're standing here at the moment. It's coming up in a few weeks' time. Just give us a sense of what you're going to be talking about by way of explaining what the current interest areas and the hot topics are, sort of thing, at the moment, rather than going through the agenda. But you see what I'm saying? I know the program reflects the current interests of the group. So where are we at within CME today? So what are you picking up at the meeting?
Okay, so I mean, things like actual getting things accredited, the accreditation standards, that's less interesting now.
Yeah.
What's taking over is what you're saying about how do you put things into practice? What's the real world kind of situation when it comes to CME, and overall with the meeting, right from day one, actually, we always said it's got to be a highly interactive meeting. So we have the cabaret table set up. Over the years, we have a way that everyone at a table has a voice. So you've got access to a microphone of some kind. So whether we had individual microphones a few years back, but it's easy access. You don't have to stand up to walk to a microphone. And the main thrust, and what I say to all the presenters, there's no blue skying. There's no sort of, I'm this incredible brain. In 3 years' time, this is what will happen in this area. No, it's got to be stuff that people can implement in their practice on the Monday when they're back in the office. It's got to be practical guidance with actual examples. Again, no imaginary sort of coming up with imaginary case studies or whatever. So this is the basis of every presentation at the meeting. And it's mostly around educational theory, how to design, develop, present good quality education. So last year we focused quite a bit on AI and the patient voice. So AI is hitting us all over the place, everyday life and things. How do you incorporate that into medical education? We will have some great examples of that this year as well. And then there is we started this sort of like a debate kind of setup last year, which we're carrying on this year. It still irks me quite a bit. We all wake up, to save patients' lives. It's all for the patient. Everything's patient. We're here to cure patients. Aren't we doing a great job for patients? And you talk to an organization and say, this is a patient-driven, blah, blah, blah. You say, that's great. What kind of patients did you involve in the steering committee? Oh, no, we didn't have any patients there.
Because we know what they want.
Absolutely.
Yeah.
And we did that. And that was the challenge we had to the group. And we have loads of patient advocates coming to the meeting, actually highlighting specifically this topic. And there was quite an eminent professor stood up last year's meeting and said, it's all well and good, you lot, the education community, talking about how you are just paying lip service to the needs of the patient. What about the needs of the learner? our actual target audience who are creating education for. And, right from that very first meeting, we always had that lunch with the learners session, 45 minutes, an hour of chatting with some local doctors who don't know anything about CME, pharmaceutical industry or whatever, just ordinary doctors plucked off the street practically, and just saying, right, what do you think of what we're talking about our world, about, how do you keep up to date and things. And so this year we're specifically, that Thursday is all about the learner and challenging our group, saying, right, how do you involve the learner? So if you think about even in medcoms or whatever, CME, any kind of education that's being even hospital layout design, how many people actually talk to the people who use the service? Yeah. So some innovative agencies or whatever might interview a few doctors. But the CME world, you should be talking to, 100 doctors or surveying 100 doctors or something to actually see where they're at and what's going on. And then looking at, well, what are their learning styles that they like? How are they going to approach the education that you're creating for them? And this just needs to be standard practice everywhere. So we're going to be focusing on the learners this year. We're in Manchester. It's my hometown, and I'm reaching out to as many doctors as I can to see how many I can volunteer. And we've got quite a few doctors turning up, which will be interesting. So yeah, and the overall structure of the meeting is, if we're looking at that on like on the Thursday, and that'll be where it finishes with the debate session. Before that, there's lots of Q&A, breakout workshops, delving deeper into this. Another topic is data. So what you mentioned earlier about how do you actually measure the effectiveness of your education? And if you're looking at ultimately above that, level 4+, you're talking about physician performance and patient outcomes. Now, in Europe, generally, we're not allowed to access to this data. And this is the big thing. Everyone sort of gives up, just going, well, we legally, we can't have access, GDPR, data protection, we can't have it. In the US, they're allowed access to patient level data. And that's why their CME environment is just so much more developed as well. And when it comes to incorporating, the patient voice and actually seeing the impact of education, you can have a whole healthcare system developing education in a specific area, track patient outcomes before and after, track how the individual doctors are doing or departments are doing or the individual hospitals are doing. But then I'm just thinking in Europe, okay, so what, we just give up? No, each country reports to the WHO outcomes data, doesn't it? You can just go on to WHO whatever it is and look at the rates of antibiotic resistance or whatever, or how people practice. It's like, who collects this data and who reports it? We don't need personally identifiable data. We actually don't want that at all. We just want pooled data. And in fact, in Greater Manchester, there's this, it's the largest healthcare experiment in the world or whatever. The NHS budget has been devolved to Manchester, and the greater, it's like larger than the metropolitan area, but the area around Greater Manchester can actually control the funding of the education, and they are collecting data. And I've had several meetings with them, and they're saying, every hospital collects this data. They're reporting it to someone, but it's not going back. It's not feeding back into educational programs. Drug companies I know are trying to do it, but I know they get rebuffed, bounce back from that. The Royal Colleges don't really use it, and then somehow it ends up with government and being reported to WHO or whatever. Yeah, why aren't we getting hold of that data? So we're focusing on that as well during the meeting. It's actually I'm inviting people from Manchester who are dealing with this data and matching them up with people from the US. So actually, I realize I'm going into quite a bit of depth, but the last point is, I don't know if people on listening in if you've got apps from your local health systems and stuff. So, I've got my MFT, the Manchester Foundation Trust, has got an app. You download it, and I feel quite foolish now because it was only about 3 or 4 weeks ago. I was going to hospital for an an appointment, and it's got my FT powered by by Epic, a massive global electronic health record company, and the Americans they use Epic data to develop education, to get the data in order to do education. as they do in Australia. Lisa Sullivan, who's like a long
Right.
friend
Yeah.
of European CME Forum, was saying, "Oh yeah, we've got Epic in Australia, and there are companies actually analyze the data and so there is this potential that we're sitting on a huge amount of data that can actually inform best practice when it comes
All
to
right.
education." It's
All
really,
right.
yeah,
So that's going to be one of the things you can bring out at this meeting that's coming up. I'm aware that we're over time as always,
oh, we
and I was very aware with yourself. We could sit and talk all day, but I did just want to pull up that because the point about the UK and the code of practice. And I know that's a very live topic, and it's one of the things that will be addressed. So just to cover that off very briefly, and people can follow up directly with if they want to know more. But can you just give us a little bit of a sense of where we're at with this? What is medical education? How is it dealt with in terms of the code of practice? Because there has been a long-standing issue around that. It's still not being resolved. I know you're dealing with it as a live topic. Can you just give us some sense of where we're at with that?
sure. So no, a few years ago, at European CME Forum, there's a group of drug companies used to get together, and they said we need a way for FPA to acknowledge how CME, independent medical education, and as far as pharma companies are concerned, how that is funded. And they created a task force that looked into this specifically. This all took a few years, but right now, today's Article 16 and Annex 3 of the FPA Code of Practice, and there's also an explanatory letter that the chair of this group wrote to the Journal of CME. So you can follow this up. Article 16, Annex 3, Journal of CME, and it explains the 4 ways that pharma companies can fund education in the loose sense of the word. So I say the loose sense because the first type is promotion, the hardcore advertising, detail aids, product information. Then you've got the medcoms type of business, disease area education under the control of the drug company. They talk about partnerships like with medical societies, and then there's the independent funding. So there are these 4 ways clearly explained in Annex 3. It needed a further explanation. And normally, each country in Europe would take the FPA Code of Practice and adapt it for their use nationally. But for some reason, the ABPI did not embrace the whole of the whole of Article 16. And it took about a year. We in the CME community it was a heart sink moment, just going, "Oh, we've been working at this so hard, and now you've done this in the UK." And the UK was they were sort of like sleepwalking into this thing. And about a year later, the members of the Good CME Practice Group were going, "Have you noticed that when you're getting funded by drug companies, they're saying it's for all doctors in Europe apart from the UK, or all
Right.
doctors in the world apart from the UK?" And you can still go there, publicly available RFPs today, download them. It'll say geographic scope anywhere in the world except for the UK. And this is because companies have been punished for, oh no, I'll do it the other way. What's happening is that UK doctors are being excluded from internationally funded CME activities.
Yeah.
Now, for us, that's terrible. So when I was running my company, I opened an office in the Netherlands so that I'd offshored my responsibilities. And then we're expected to geo-block UK learners. There are satellite symposia that even took place at the ESC last year, where British doctors were not allowed to go to a satellite symposium at a conference taking place in London. It's utterly bonkers. And so Good CME Practice Group wrote this up somewhere, but Friday morning, I'm getting some local experts together. So code compliance people, people with experience of the PMCPA. I'm hoping that someone from there who've got the responsibility today can come to the meeting, but also from the Royal Colleges, because ultimately the pressure, whoever I've been speaking to is saying, well, no one's told me that's a problem. British doctors, oh, we've got so much education already. Do we need any more? The colleges are going, well, the doctors aren't complaining to us. ABPI, PMCPA, no one's complaining to us. And it's like, yeah, apart from the drug companies can't operate properly, and we're isolating the UK. Yeah. So we're going to try and unpick this. Apparently, there's some great, there are a lot of people actually now working on this. You can track conversations on LinkedIn and stuff. But Friday morning, we're going to really focus on this.
And it sort of all comes down to the fact that in the PMCPA code, it doesn't define education, does it? Or it doesn't even really talk about education, does it? It's assumed that everything is promotional, and therefore that leaves that question mark over education. Okay, look, we're way over time. I really wanted to get that last bit in because I think it's a really interesting topic. I mean, ever since I was involved with European CME Forum, there's been elements of that, and it's become more, as from what I can see, more and more of a serious issue. And it just seems to be holding up a lot of good intentions. I mean, there are people trying to do good education, and those sorts of problems are real practical issues for people. And I guess it just sounds like people should just sit down in a room together and sort it out. And that's what the European CME Forum is trying to do. But boy, does it take a lot of time. So let's just wrap it up there. There's so much more we could talk about. I want to encourage people to talk to you directly. LinkedIn is an obvious way of doing it. Yeah. The website address cmeforum.org is the place to go for all that information. At the moment, go and find out about 18 ECF, if I can get the word out. After that, I guess 19 ECF and so on and so forth. But that's the place to go for all this information, and you're the man to talk to. So please contact you via LinkedIn. Yeah. Thank you so much. As I say, I've enjoyed it, but I'd love to be talking for more. But for the moment, thank you very much. I think that will help people. But I'm going to close the recording down and say goodbye. And I will just make a little plug for me. If anybody's watching this and wondering what I'm doing, Network Pharma TV. Okay, take care, everyone. Cheers. Bye.